各位同仁，那我们接下来进行下一个这个 session， 那接下来是国外讲者了哈，那所以我们就开始换成这个英文哈。Dear colleague, ladies and gentlemen, it's my great honor to chair the second session with Professor Wu Dongxin. The topic of first talk of this session is AI in nuclear medicine. It's a very hot research issue in recent years. The speaker is Professor Piotr Slomka from School of Medicine, UCLA. As you may know, he also the chief scientist of Cedars-Sinai Cardiac Center. So far, he has published so many important papers about AI and deep learning for nuclear imaging, especially for nuclear cardiology. Today, he will show us the latest AI development in nuclear medicine. Let's welcome Professor Slomka.
Thank you very much. Can you hear me okay?
Yes.
Okay, very good. So I should share my slides, I presume, right?
Yes.
Yes, okay. One second. Can you see the first slide?
Yes.
Okay, so I think we're all good. How much time do I have? I just want to make sure we have 30 minutes?
Yes, 30 minutes.
All right, very good. Thank you very much for inviting me. Taiwan is a special place in my heart. I have been there many times. I have very good friends, Polish Taiwanese friends. This is the one picture from our meeting where I was able to actually be there physically. I hope sometime I can come and visit you again. Your beautiful island is amazing. We had a lot of good food there and see also nature. And it would be nice to see you in person sometime, all of you. These are my disclosures, the research support and commercial disclosures. We have a lot of collaborators which help us to put all those things together. Amazing people we are privileged to work with. This is the team which collaborators from different countries which allowed us to put together data sets and CEDARS collaborators. So I know it's a nuclear medicine meeting, but just a little reminder about nuclear cardiology. So in US at least, we perform 7 million scans per year of SPECT MPI and PET MPI. I think in Taiwan, you also do a lot of this cardiac nuclear cardiology images. We have ways to quantify the data. We have various variables. So we are in a way quite further ahead than some other modalities in this respect. A lot of quantitative tools have been there for a long time. And the physicians are tasked to put everything together, provide risk, and quantify these images, and so forth. So I will talk today a little bit about nuclear cardiology. Those are general topics, but they will be like shown in the nuclear cardiology context, how we can develop AI systems for nuclear medicine and nuclear cardiology, in particular, how we collect data for these systems, how we do automated analysis, how we can do image improvement, diagnosis, and risk prediction. So those will be like 5 topics today. We'll try to move fast so we have time for questions. This is the cartoon which my daughter has drawn. And as you can see, it's a big, difficult task to get data. One of the projects we have, we call it Refine SPECT, where we collect data from various centers, images and nuclear cardiology and clinical data, which then we can use to optimize the AI systems and learn how to best improve the information from these images. So this project started a few years ago. Those are the original centers. At that time, we had 20,000 cases, and we follow up these cases for events. So we have 3,500 people had major adverse cardiac events. We call it MACE. And we then can try to see how these images can be improved and how can diagnosis be made better to predict these events or to predict obstructive disease. But right now we have already almost 44,000 cases, and there's more cases ongoing for SPECT. We also have a project in PET ongoing. And you think it's a lot of data, but actually it's not so much data. This is the typical USB drive, which is about 8 terabytes. It's a very small drive, which will fit in my hand, basically. You pretty much can fit all this data on one drive. So it's not a lot of data, but it's very diverse, and we can utilize it for many important projects. Some of the things we could do when we have a lot of data from different centers, for example, we can develop some AI model on one population and then test it in a different population. Here's an example from one recent paper when we show risk prediction, and we see that in this internal cohort of 20,000 original 1,000, we have a relative risk prediction of 6 times by some particular analysis. And then we apply it to a different cohort, which is at 2 different sites, and we get like 6 times risk increase using that model. So this is something called data hygiene, where we can keep training data separate from the testing data, and having multi-center data allows us to do this. So we also embark on a refined PET now. We have a lot of cases ongoing. These are new projects here at Cedars-Sinai, and in collaboration with centers such as Brigham and some other centers around the world in PET. So we will be doing a lot of this in PET area as well. So first, let's talk about image analysis, automated analysis. So recently, we spent a lot of time on deep learning, and I think you are very familiar in Taiwan and with deep learning. There's a lot of interesting techniques. Some of those techniques can be, for example, used to classify images, like those kind of early papers where we were able to classify, for example, this is a standard kind of network, which is the input are images and the output will be some kind of label, like is it a car, is it a bicycle? Then we have ways, this is actually a very famous paper on UNet about segmentation, where we can transform images, and we can transform images from one form to the other. And for example, we can segment images this way. Or we can transfer images, which we can create some kind of different kinds of images, like in this video application where we make a zebra out of the horse. And so those are the standard computer science techniques published by very smart people in the computer science. And we're just trying to see how these techniques can be applied in medical imaging. So one application I want to show you for automatic image segmentation, image analysis is calcium scoring. You're familiar with this non-contrast cardiac CT. It's not really nuclear medicine scan, but most of our now SPECT CT and PET CT will come with this kind of CT attenuation correction. I just want to show you some of the things which can be done with those scans, where we can look at this calcium deposits, which is a very simple test, and it could be very useful. In this recent publication, we have shown that by Konrad Pieszko, one of the postdoctoral fellows in my lab, we've shown that if you do dedicated gated coronary calcium scan, or with an expert reading, versus you can do a CTAC, CT attenuation coronary scan, attenuation correction scan, with a very low dose, with no gating, you can do this kind of segmentations with deep learning using this kind of, in this case, convolutional long short-term memory network, where you can automatically segment within seconds the scans with very good accuracy compared to the users. But importantly, prognostically, if you compare this to this dedicated calcium scan versus this PET CT, in this case scans, we get exactly the same prediction for major adverse cardiac events. So you can see that there is like hidden data in nuclear medicine scans, the CTAC scans, which have not been used traditionally for this in this manner, but they could be used using this AI techniques. It's very fast. It will not, add too much to the workload. We also tried this in SPECT-CT. The SPECT-CT, when we do SPECT scans, we have a CT scans, and we've shown that actually not only it can segment automatically, like you see here, expert reader deep learning, but it actually adds to the prediction. It will reclassify cases more correctly when we have this additional information, which is usually not used right now. And here is a sort of like a table where we compare these deep learning scores with the expert scores, and you can see there is a good agreement. There's some, there's some dispersions here, but as you've seen prognostically, it doesn't seem to matter. And of course, the scans are low quality and so forth. So there is additional complication. This is Rob Miller from our lab. So moving on to the image improvement. So this was the automatic analysis segmentation. We, of course, can do nuclear medicine segmentation. There are other algorithms, but I just show you something different, a little bit CTAC. But now let's talk about image improvement. So this is a famous technique from computer science applications, which is called generative adversarial networks, or also called GAN, where you can train network not in a way that you try to resemble the image, but you try to train it in so-called adversarial fashion. So what that means is that, for example, in this case, this is one publication, sort of generic publication, which is using this technique. It shows that from one image, you can generate a talking video. When you can give this marionette here, this can be dangerous, as you can see in these times, where people can put this fake videos, of course, where they can put something in the mouth of the person which the person doesn't want to say. But those are how this algorithm has been shown, and people, use them for different purposes, unfortunately. But the way this works is that you have a generator which generates these images, which are sort of like, we call them deep fake images. And then we have discriminator, which is try to recognize the true image, which is actually made from a real video, and try to recognize the difference. So once the images are generated as good that this discriminator cannot distinguish the true versus the real, that the network is trained. So that's what's called adversarial fashion. The system is trying to fool this discriminator, and once it's fooled, it will work in a way that these images are virtually indistinguishable from the original video. So this application, is kind of not in our field, but how can we actually use it in nuclear medicine? So here's an example, not from our lab, it's a different publication from XURE, from European Journal of Nuclear Medicine, where they show example for this GAN network for denoising, where you can try to train the system and show and then compare them to the images. You'll be comparing these images to the images which have which are generated from less counts versus images generated from full dose, and then try to make them indistinguishable from each other. You have this generator here and discriminator. And so here's an example in a brain imaging where you see that this AI enhanced images, which the dose reduction may be as low as 10 times less counts, or it could be faster scan, are similar to those images which are non-AI enhanced. So maybe we can argue it's 4 times here. Maybe that will be more similar. But you can see how you can enhance images in that way and train the system to learn how to make this, for example, in this case, faster images or faster reconstruction. So we actually tried something a little different. We applied it to attenuation correction. As you know, in SPECT-CT, especially in cardiac imaging, we really need to have attenuation correction. However, often we don't have the CT. We just have this nuclear cardiology, just a standalone scan. So this is the problem. Less than 10% of the scanners, especially these new scanners with this hybrid CZTs crystals, they don't have CT. So we tried to see if we can apply this kind of GAN techniques to see if we can generate attenuation corrected images from non-corrected images. So we had in our refined SPECT, we had about 5,000 cases. We're using internal with training validation from one site, and then we apply it to test it where the data will actually have a CT angiography, anatomical angiography, a different site, we can apply this model and see if we can actually generate this kind of images and see how good this can work. So again, this is this kind of architecture of GAN where you have non-corrected data, you try to convert them into this deep AC, we call it, and compare them to actual real AC. And then once the system is not able to distinguish those two, then the select 3D stacks of the slices. While the system is not able to distinguish, then the network will be closed, finished. So here's the example, and you see here no correction. So the traditional inferior wall defect, you see it on a polar map also. Total perfusion deficit in this case was 11%. It wasn't able to find, that this was an artifact. This is an attenuation corrected image you can see here, and here is a deep learning image. And importantly, I think this was the first study where we could show that actually in external validation, we look at the performance, diagnostic performance, and the blue curve is the attenuation correction with CT. The gray curve is this deep AC applied in totally new hospital, where you can see that it's slightly worse, but it's not significant. And you have no correction, which is a big difference when evaluated with CT angiography. This was recently published in JNM 2022, Akash Shambak and Rob Miller. So now moving on to a little bit different topic is, first, I've shown you that we can kind of segment images, we can improve them, but what about diagnosing? What about the things we can, the physicians do and diagnose from these images? So here's a study by Yuka Otaki and Anya Singh from our site, JACC Imaging 2021, where we show that we can actually feed polar maps into this kind of network, and this would be similar to this kind of first networks, which is detecting cars and boats in the images, and we can feed all kinds, feed here different kinds of polar maps, perfusion, motion, thickening maps, and then we can derive at the end probability of the disease. This will be trained by the angiographic cases. We can also feed some additional information such age and gender, which is sort of like fundamental for understanding the images, and also the volumes, because the volumes is not something you have in this polar maps. We can then generate this kind of segmental scores where we can give scores, this deep learning scores for each segment, and we can generate also the CAD probability and give an overall probability of the disease. And we can also show, in a way, explain to the physician which part of the image is driving this conclusion, this diagnosis, by showing this GradCam, where it sort of propagates back the network to find out which part of the network is responsible for this high probability. And as we can see here on these curves, the sensitivity and specificity is, if we have the same specificity, we can improve the sensitivity as compared to the expert visual readers at the sites, about 3%. Maybe that's not very much, but considering 7 million scans a year in the United States, it's quite a lot of patients here. A couple of 100,000 patients could be here. And you can see ROC curves here for the same. So this is a clinical prototype where we show how this can be sort of clinically implemented, where you show to the physician, show this attention map, GradCam maps, you show these segments, and you have the probability of disease in this case. This case, it had 85% stenosis in the proximal left LAD. Processing time end-to-end is about 5 seconds or something like that. It's not very complicated. Why this is important to show this attention maps? Because here is a paper from ZEC plus Medical, where you can see that in the task for detecting pneumonia, the system was showing that it was detecting pneumonia very accurately, but it was showing it in the shoulder. How can the pneumonia be in the shoulder? Even for a PhD scientist like me, it's obvious it's not right. So what you see here is that there was a metal token from a particular hospital which had a very high incidence of pneumonia, and that system was basically using this as a proxy to predict pneumonia. You can say it's cheating, and that's how you can kind of see that this is very useful to see what the system is trained on, how it performs, and what is using for the physician to use it in the clinical practice. We also try to use this kind of attention maps to show it to the clinicians. A study by Rob Miller, recently published in Journal of Nuclear Medicine. We wanted to see if the physician without AI, this is a today standard, we read the images with the stress results, we score the images, and we get the polar maps and so forth and images. versus the physician actually will get an AI and see if it, and will get these images, and it will help them, will it help them to analyze images better? And as you can see here, different physicians will have different responses. On the average, it does help them. But they cannot, physician with the AI was about the same as AI itself here, the blue and the red. What's interesting is that some physicians were really helped by this. They were really, we can call them, they believe in this AI, and they were upscoring the images more according to what AI was showing them. And they were getting a better, better increase in sensitivity and specificity. This physician would be, never trusted when it shows the higher sensitivity, but always trusted when it showed this false positive results, which would just try to, show that something is false positive. The physician will believe in that. And this physician we can call cautious skeptic. He just didn't like this AI and didn't believe it. So you can see that using AI clinically like this, it's not just AI on its own. It will be the interaction with the physician and AI, and this will be the final output. So this will be, we need to study it a little bit more. We also have issues such as bias in cardiology and in medicine in general. And whatever the system is trained on will reflect that. So if we train the system with too many cases, with abnormal cases, the system may be sort of overcalling cases, which are normal. And this can be shown on this kind of Breyer scores, where you show the actual, in this case, prevalence of obstructive disease versus the score, like how well the score will reflect it, like what is the probability of the disease. And you can see if you train the system with a lot of abnormal cases, it will, especially in women in this case, will just be under, it still will be correctly, if you have some threshold, be correctly diagnosing, but we're giving too high of a probability of the disease. So this is called a calibration score. So if you start, what you can do is you can augment the cases. You can start adding cases, more and more cases with, like, for example, normal cases. And in this case, it will be more and more resembling the actual, probability distribution of disease will be what you will get in your testing data. This can be also done, like, for example, for women or for different races and so forth, to just balance the data. This is called data augmentation. This is a recent paper by Rob Miller and Anya Singh in European Journal of Nuclear Medicine. So just moving to the last topic here. So this was diagnosing of the disease. Here we'll move to the predicting of events. So here I just want to show one topic, which is maybe familiar to you, that in nuclear cardiology, we want to sometimes do only stress scan. We don't want to do a rest scan. But we want to know when it is safe, when you can safely cancel. It turns out that you can maybe cancel up to 60% of the rest scans. You just don't need that scan. And this is done, the cost, radiation, time is really not very good. Current cancellation is about 3%. At CEDAR, this is maybe now 25% we see. So this is an old paper published 12 years ago to show that you get the same risk when you use just stress only. You try to have some clinical criteria. So actually here, Dr. Lin Xin Hu from Taiwan, who was at our institution for 1.5 years almost, we published the paper. She published this paper in European Journal of Cardiovascular Imaging, that you can actually have an AI system. This is not a deep learning system like a classical AI, which can detect risk very accurately as compared to this TPD or medical diagnosis. And you can have a threshold, and you can have different kinds of thresholds on the ROC curves. You can see these points, those are thresholds, which will always outperform what a clinician can allocate for risk. And you can see here that if you wanted to cancel 60% of the candidates for cancellation, if you use the physician reading, the risk of these patients where you cancel the rest scan will be for MACE will be about 2% over per year. If you use AI, you can cancel 60%, and these people will have 1.4% risk. So you can stratify these patients very differently, and at the same time cancel the same proportion and have a much less risky population in these people where you cancel. You can also explain why you're canceling the scan, and in this case, the overall risk, will be pretty high. This will be the barrier where you would cancel, And you can individually for each patient look at these different risks. And even in the images that are very slightly abnormal, there will be some other risk which put that patient at the higher risk of MACE, where you may want to have this both scans, stress and rest. So you can show these graphs. We call it a waterfall graph, where you can show the de-risking in blue and up-risking it in red for individual features for individual patients. And this can be shown to the physicians. We also, in another application of risk prediction, you see here in PET, we always have the flow and perfusion. And there is this classical paper from Dr. Murthy, where we can see the perfusion defect and the flow, and we can see how the risk is being assigned differently based on this perfusion or flow. But how can you use it clinically? You will have to divide it into these tertiles. It's very arbitrary. But turns out that you can, with AI, you can feed both perfusion and flow images at the same time using this kind of AI network. And you can then, in this case, this is a PET population from Cedars-Sinai, where you train in 3,500 cases, then prospectively testing in new 1,135 cases. We can then generate the annualized risk and this attention maps. And you can see here that if you use ischemia, 10% ischemia, which is the threshold in the research ischemia study, there's very little risk stratification between blue and dashed red. But when you apply this low and high score based on this perfusion and flow, you can see how much better reclassification is when you have this kind of composite factor. And here from this paper, from Ananya Singh paper, circulation imaging, you see that even if you take a normal visual scans, you will have a very good discrimination for risk or abnormal or males or females. It works extremely well in all these populations. So with all that, it's an overview of things we do. These are generic things, but cardiology, nuclear cardiology things, but they apply to other parts of nuclear medicine. Importantly, clean, well-characterized data are essential for artificial intelligence. Data are key here. AI can be harnessed to improve image quality, which the systems like that you see already coming out from many sites and many labs. AI can also segment data very accurately, like you see on the CT scan. You can perform diagnosis directly from images, and you can integrate it with, for example, flow and perfusion and so forth. And this is a picture of some of our team members. Thank you very much.
Thank you, Professor Slomka, for the wonderful talk. It is really exciting to see how and what AI can do to improve the images and the diagnosis. Now we'll open for discussion and question. Is there any colleague want to share your comment or question?
Hi, Professor Slomka. I remember you have a slide is talking about the CT attenuation correction for used as the calcium score as a predictor to to use it to predict the cardiac major event. So I just want to know, should we consideration about the difference between the gated CT calcium score and the non-gated CT attenuation correction difference in the fundamental image parameters?
Yes, thank you very much. So indeed, there is a big difference in this quality of images. And first of all, when we have this CT attenuation scans, they will have no gating. They will have a much lower tube current. So the parameters, the acquisition is more noisy. And people always think that this is not really possible to quantify this very accurately, this calcium. But however, we've shown in 2,700 images that this automatically quantified scores, not corrected by anyone, they actually can risk stratify very similar to this scans. In these scans, we actually had both. We had the CT attenuation correction scans, and we had this gated higher end scans, which had about 1 to 3 millisievert dose versus like about 0.25 millisievert dose on those CTAC scans. The CTAC scan had the current was about 11 to 13 MAS. They were both 120 kVp. So much lower quality, but at the same time, it was still possible to derive this calcium scores. I don't know if that answers your question. Yeah.
Another question, if I am interested to use the similar study, should I need to do any modification on the CT attenuation correction, for example, as SPECT CT or PET CT? So my question is, should I need to do any modification and then to use this kind of image for further analysis?
Yes. So what we've shown that on the standard CT attenuation correction, not done with any modification, those are standard attenuation correction scans, you can do this. So there was no need to change your protocol because these images were collected retrospectively. They were collected from the refined SPECT registry, and in that case at Cedars-Sinai, they actually were doing gated CT scans because they didn't believe they can use attenuation correction for this purpose, and then we shown that actually it works on those standard scans. Those are the unmodified protocols.
Professor Wu, please.
I'm Dr. Wu from Taiwan. I think your talk is really inspiring. I have several questions to ask. The first is that AI is a black box. How do you define the individual component, the importance of the individual component in this model? The second one is that, as we know that nuclear scan may have a lot of confounding factors, including the race or ethical groups. Do you think that you have to validate your AI model in different ethnic group? The third one is that we try to evaluate the importance of the MPI. However, if we put more clinical parameters, we will find that the prognosis or diagnosis accuracy, the clinical parameters is outweighing to the image parameters. How do you think about that?
Okay, thank you very much. So 3 questions. First question I think you had was about the black box. So I would say that we try to make sure that AI is not a black box. So for example, when we work directly from images and we predict diagnosis, we use GradCam technique to highlight on the image. So basically we propagate back and it shows you which part of the image activate the prognosis. So inside, you know, the weights, of course you can't see every weight of the million weights, but what you can see, which part of the image exactly is most important for this diagnosis. The other part of this black box is that if you don't use images, but you use features, for example, you put 20 different features like stress perfusion and TID and maybe size of the heart, and you want to know for that patient, how does that, is it important when you get some risk prediction or some diagnosis? So AI has techniques, and the techniques we use, we call gradient boosting. They have an internal technique that you can see for a particular case how many times it was used in the internal algorithm, and it will tell you that feature is like the most important for that patient, not on the average. So there's also techniques called SHAP, which are more generic techniques. There are some issues with this. We don't know really how to validate it. It's difficult to validate this because you show, okay, this feature is important for that patient, but how do you know the AI is correct? So there is a lot of issues, but you can show these things, okay? So I believe you can explain, you can show. Similar like to any other system, really. Now, the second question is the bias, I think, was the gender and race and so forth. Very important. And I think we want to make sure it works equally for everyone. But, really, like when we had standard techniques like a percent defect, TPD, or if we have flow, perfusion, myocardial flow reserve, we don't really know if it works for Black people in America or for Asian people. We don't really know this. This is a new topic which people like to, it came up because of AI. It's maybe more interesting now, but it was always there. So I think we need to learn how to make it unbiased. It's a very important topic. And for example, I showed you these techniques with guns, how you generate images, sort of fake images. So one of the approaches people do, for example, if our population doesn't have a lot of Black Americans, we could actually generate, like make more cases for the training to balance this, or men and women. We can balance it by this called data augmentation. So I think it's a very important topic, and we have to work with it to make sure it works for different populations, because we don't want a system which actually underperforms in certain groups. And the third question I forgot right now. I'm sorry. It was
when I try to evaluate the importance of the MPI prognosis value, we find that if we put more clinical parameters, the clinical variables will outweigh to the image findings. How do you think about that?
Yeah, so I think you're right, and it depends. I think we actually have some papers now ongoing that clinical parameters are very important, and it depends on prognosis for how long. So for example, if you want to have 10-year prediction, maybe clinical is more important than image. But if you want to have 1-year prediction of some event, maybe image is much more important. And we actually show, didn't show this work, it's still under revision, but you can actually see that short-term prediction, images are very important. Long-term prediction, maybe clinical data is very good, and maybe the image is less important. And also it depends, I think, for what you try to predict. If you try to predict heart attack, maybe images are very good. But if you want to predict all-cause death, that someone dies, maybe clinical parameters are much more important, because there's other things there. So I think we have to learn more, but it's certainly important question and topic. Thank you very much.
And I have one comment to ask. I just come back from HA in Chicago. I think the CT has a very promising role in the future, especially in the cardiologist point of view. How do you think about it? Because in current guidelines or recommendations, the importance of nuclear scan is downway. So how do you think about it? Do you have any comments to improve that?
I think that, if there's of course a lot of CT angiography now with AHA, and there's the CT FFR, but there was like a recent study show that actually FFR is not important. Maybe there's a lot of discussion about this, but I think it will change. I mean, there was a ischemia trial showing that nuclear medicine is not important, but I think we have amazing technique in nuclear medicine because we actually have a SPECT CT or PET CT. So what I showed you with the calcium scan, I think if you have a nuclear cardiology scan plus calcium scan, which it comes for free, together is an amazing package, because together, if you take nuclear medicine with all the perfusion and calcium, and maybe a little more you can get from that CTAC, which people just use it only for attenuation correction, but now you can use it for more. Put it together, and maybe this is much better than CTA or the same. So I think we have a long way to go, and I think especially in PET, there's a lot of flow techniques, a lot of new things. There's so many things, and I think AI will play an important role, and will give a CTA a run for its money. So
thank you.
Any more questions? Dr. Hu, please.
Hello?
Yeah.
Hi, Piotr.
Hi, Lisa. Nice to see you.
Nice to meet you. So I have a question. Do you think, I see you're doing the integration of flow quantitation with MPI to diagnose CAD. Then, so I assume that you don't think absolute quantitation of flow will replace MPI SPECT. And why it isn't? I mean, if it's an absolute quantification, then is it a standalone, then is accurate enough to diagnose CAD? What's your opinion?
Yes, so my opinion is that the flow is a very interesting modality. We work a lot with this. It's a very difficult technique. I think the quality control for flow is much more complicated than like a simple perfusion scan. There are cases I can show you from our lab where we see the flow just doesn't work. It makes no sense. And it could be some technical issue. Maybe patient had a caffeine or something. It's not, or something went wrong with the injection, or there was some saturation that there's so many things which can go wrong more during the acquisition. It's more complex. And I think even if it's perfect, there's some physiology questions which we don't fully understand. And I think maybe with ideal tracer, with ideal technique, maybe that would be enough. However, we still show that the perfusion, it still adds value to flow. There could be, there are just some different kind of scenarios where the flow itself may not work very well. So I think they will always come together, and especially the perfusion, it really is always there. It's for free. The flow, you have to do a little more because you have to acquire the scan, right after the acquisition and everything. But the perfusion image is always there. It's very simple. And as it is in US right now, only perfusion is really reimbursed for the patient scan, even with PET. The flow is just a little add-on, which is not really considered like a main clinical application. So I think we have to see and wait. I think it's very interesting, very important, but the perfusion is still the main workhorse, and I think we have to use it together. So that's how I think about it.
Thank you.
I guess we still have many questions to ask about, because of the time limitation, we have to close this section now. Thank you, Piotr. Thank you again. Wish you can come back to Taiwan very soon. Thank you.
Thank you.
Bye-bye.
Bye-bye.